Unfortunately, for the review, I can't have this recorded. It's an A to P elbow, and then what structure is this?
The medial epicondyle.
Medial epicondyle, good. So remember, when you guys are giving me names of views, make sure you tell me if it's A to P, make sure you tell me the region too. So this is an A to P elbow. Number 2. Trochlea, good. Capitulum, capitellum, however you want to say it. I am fine with either one. Olecranon process, good. Good. Lateral epicondyle. Olecranon fossa. If there were a hole in it, what would it be called?
Olecranon foramen.
Olecranon foramen, good. Good. Distal metaphysis of the humerus or distal humeral metaphysis, perfect.
Distal humeral diaphysis.
Good. Distal humeral diaphysis. Perfect. Radial head. Yeah, humeral radial joint, or if we want to be just a little specific, radial capitellar joint. I am perfectly fine with you guys saying humeral radial, okay? So either or is fine. Yeah, either our humeral ulnar joint or ulnar trochlear joint. Good. Perfect. Got the neck here. Perfect. Radial neck. Number 13.
Radial ulnar joint. Or radial tuberosity.
Yeah, good. Our radial tuberosity. That structure there. Yeah, coronoid process. Good. Okay, that's number 15. Good. Proximal radiodiaphysis. Good. Proximal ulnar diaphysis. Perfect. All right, 17. So I'll tell you, 17 and 18 are going to be two different things. Well, you already have the answers. So this was supposed to be the joint space for 17, proximal radial ulnar joint versus the radial notch. But they're so close in proximity that I would accept either or for you guys, okay? So will you have the indicator like this on the exam? I may have shading, or I probably would have a hotspot question. And if there were no color here, I would expect, if I were to say, to point out the distal radial, proximal radial ulnar joint, I would make sure to have like the box that I would have you guys wide enough so you could pin the question like here or here, something like that. Yeah, I wouldn't have, if I were to put this as a multiple choice question, I would not put radial notch and proximal radial ulnar joint in the same question for you guys. That would just be too evil. With the exam, you guys had a quiz and something this morning? So yeah, distal humeral diaphysis, perfect. Distal humeral metaphysis, perfect. All right, let's see if you remember this one. Awesome, medial epicondyle. Good, our coronoid fossa. So the coronary process would go right into there. Awesome. Yep, so Legrenard process would go into that fossa. Trochlea, good. So again, the little teardrop is medial epicondyle, and the circle is trochlea. Perfect. And there might be some trippy ones. So what's this one? So look very closely at it. So if we're looking at the trochlear notch, it would be kind of like here. But yeah, but this is actually the capitulum or the capitellum. Good job. Like I said, I'm not gonna trip you up on that, okay? But good for making that catch, because we do see that it's extending beyond that trochlear notch, and there is articulation with that radial head. Now here, that one is our trochlear notch. So hint, hint, wink, wink. If I were to give this on an exam, I would only give you trochlear notch. I won't give you capitellum. Okay. C is always the answer. Don't put all C, please don't. Again, we see coronary process. And here we have olecranon. Radial head. Got the neck. Proximal radial diaphysis, perfect. And then 32, ulnar diaphysis, proximal ulnar diaphysis. That's 32, 33. Good, radial tuberosity. So if we look at that again, we can see that there's just a little bit of decreased density. Can mimic pathology, but if you know where the general area of that radial tuberosity is, you should be comfortable saying that it is what it is right there. Okay, so before we get to this area here, yeah, the anterior fat pad. So we can see just a little bit of that density present there. So again, the anterior fat pad is fine to see as long as it doesn't become like so. Okay? So you don't want to see that triangular configuration or that sail sign. Perfect. And then you never want to see a posterior fat pad. So no here. Okay here. Alrighty? Alrighty, so here, this isn't asking for the joint line. I'll tell you that. It's not asking for the joint line. Yeah, exactly. So it's looking for the trochlea. here again. Yeah, what is this view? Good, it's our Jones view. So the arm is in full flexion. Yeah, sometimes when we do these images, this was taken in our clinic, and for whatever reason, sometimes it inverts the image. So it's just a marker. It's still a right elbow that's being X-rayed. It's just for whatever reason it's switched on the computer. Good. I like Renan process. Now this one's asking for the joint line. Humor ulnar or ulnar trochlear. Good. All right, what view is this?
Lateral.
Yeah, this is our radial head view. Let's see, this radial head is well projected on this one. What's that? Yeah, good. It's the capitulum capitellum. Remember, it articulates with the radial head. So just remember that, and you're good. Okay, before we get there, we can see the proximal radial ulnar joint pretty well here. And then this portion here is our radial notch. You may not always see it this well on a radial head view, but this one is just so pretty. I had to point it out. All right, identify the view.
AP weighted.
So yeah, so this is A to P internal rotation.
Oh.
So remember, if this was an ice cream cone, that radial shaft or that diaphysis was the ice cream cone, the humeral head is the ice cream scoop. That scoop is in the cone. Are you guys taking ice soon? Okay. So yeah, this is lesser tubercle or lesser tuberosity, either one. So the greater one is overlying here, so it's all that part. So that's greater tuberosity, and then the lesser one. So you see the lesser one medially on our internal rotation. Superior angle of the scapula. Perfect. Okay. Identify the view. A to P, external rotation. Ice cream is slipping off of that cone. And then we have here. Good, our glenoid fossa, perfect. Good, it's the growth plate, or we can say it's the physis, or the proximal physis to be a little more specific. Remember, epiphysis, physis, physis, metaphysis, diaphysis. EPMD. Isn't that a group name or something? Is that a musical group? I feel like I've heard that before. There you go. "46. Did I trick you? I did not trick you. So we're seeing both aspects of that physis. So remember, we're just seeing one portion from one side of that cylinder that we have, and then the other side. So that top one, that more superior one, and that more inferior one all relate to that physis. All right, 47. Yeah, good. Coracoid process. So coracoid in the shoulder, coronoid in the elbow. So this view, this is just to show, I don't know if we covered this one. I can't remember if we covered this one, but this view is, so don't worry about it. This view is to highlight the entirety of the clavicle. So this is just an A to P clavicle, or we call it axial clavicle view. So again, don't worry about it. Yeah, it does look like there's a little bit of forking going on there. Good catch. You did do a thing. There's another one too, though. I'll ask in a couple slides. Oh, there's another one too. So what's number 49? So look very carefully. Look at that humeral head. We have open growth plates still on this patient. So we won't consider this an osteochromiale yet. So this is just a secondary growth center or still an open growth plate at the acromion process. So you have to look very carefully to see if this patient was skeletally mature or not. So once they reach skeletal maturity, that everything is fused, then we can call it an osteochromiale. All right, number 50. Good. So we have the conoid process or conoid tubercle. I'm fine with either one of those. So coracoid, conoid, coronoid. All those to remember. '51. Oh, that's good to remember. They go in alphabetical order from superior to inferior. Perfect. So yeah, this is our anatomical neck. Good. 52. Surgical neck. 53. Good, our acromiohumeral space. Good job. So I'm not worried about numbers right now, but if it becomes diminished, so if this humeral head ends up saying like here and that space is like so, what would be the implication for that? Could be due to arthritis. They will definitely have some impingement in the area. Usually when the humeral head migrates superiorly, it's most likely due to a rupture of the supraspinatus muscle. All right, what's the view? You guys are ready for it. So Grashey. So remember, no osseous overlap between the glenoid fossa and the humeral head. Good. All right, let's do some wrist stuff. Scaphoid, perfect. Look at the handmade, perfect. Or your hamulus, awesome. So I may mention that all of these were known as our intercarpals, but more specifically, what is that between which bone and which bone? Scapholunate, perfect. So it says it should look similar to other surrounding intercarpal joints. Should measure more than approximately 3 millimeters. Don't worry about that. Just know that it shouldn't be more than that, because then we'll have something called a Terry Thomas sign, or we call David Letterman, named after people that have a gap in their teeth. So that's where they get that from. I've also heard it called the Michael Strahan sign as well. Just a little FYI. Next one. Capitate, perfect. Yeah, so this is the entirety of the hamate. And then this joint between this bone and this bone. Lunotriquetral. Again, just another little FYI. Still, these are all collectively called the intercarpal joints. Good. That more oval, rounded bone is our pisiform. Yeah, trapezoid. Remember, trapezium is with the thumb, and then the next one is trapezoid. So I just gave away that answer. So that's our trapezium. Distal radial ulnar joint, perfect. Yeah, so it is essentially an anterior fat pad in the wrist. But we name a little more specific to the pronator fat pad. Alrighty, this little crescent shaped bone here. Good, this is our lunate. Go back. What's that one? Triquetrum, good. Awesome. Capitate, perfect, and that's the bone that the capitate sits right on top of that lunate. Good, trapezium. Uh-oh, what's this one? Take the color off again. What's that right there? A scaphoid. Yeah, good. This is the radial styloid process. Good job. Okay, now it's this one. Now, we've already pointed out the triquetrum there, and trapezoid would be somewhere here. So, yeah, this is actually our pisiform. And I think capitate just overtakes too much of the hamate, so it's going to be hard to differentiate that one as well. Good, our ulnar styloid process. that's our scaphoid. Just partial, just as much as we can see. That could be the little rubber ducky head. The view. Just went over this one. That's our angulated scaphoid. Good. Remember, it really highlights that scaphoid. It elongates it. It's elongated, angulated scaphoid. And there's a PDA of the hand. It says right here. Pip joint of the third digit, third pip. Fourth metacarpal head, perfect. Next one. Base of the third metacarpal, perfect. What bone is that? Good, so we have scaphoid, lunate, and then triquetrum right next to it. Perfect. Second metacarpal shaft, perfect. Distal phalanx, fifth digit, perfect. Yeah, this was an oblique hand view for this one. You're welcome. And yeah, good. Middle phalanx of the second digit. Good. Number 82. Yeah, good. So we have secondary growth center of the first metacarpal. And remember that the growth plate is open at the base of the first and at the heads of second 2 through 5. And if there were a open growth plate, say here, what would that be called? Supernumerary epiphysis. Good. What view is this? Not ulnar deviation. Yeah. This is a ball catcher view. Because it really highlights that structure. Which in our next one is what? Our pisiform. Remember, ball catcher really highlights that pisiform. the normal variant present? Perfect. Our Olecranon foramen. Notice the complete lack of evidence of bone in this region. Remember, it will always appear more loosened because the fossa in this region. Don't mistake this for normal loosened appearance with the foramen. And then just showing again what the normal olecranon fossa is. Oh, sorry. I clicked too much. So yeah, so right here, this is our osteoloideum, and it's approximately in that area. So again, you can have multiple ossicles in the hand. This one's a little more significant because it's one of the few that can actually present with pain, especially if the patient does a lot of hyperextension to that area, or a lot of small motor skills. Or maybe associated with dorsal wrist pain. Anatomical variant here. This whole hand looks a little weird, but the main thing is that just shortened metacarpals. So it's associated with something called Turner syndrome, but I just wanted you to point that out. And yeah, you would have a disrupted metacarpal line because there's nothing intersecting here or here. Good. So if you look at that ulna, look at the articular surfaces between the two. The ulna projects shorter than the articular surface of that distal radius. Therefore, we had a negative ulnar variance. And what was the association with a negative ulnar variance? Yeah, you may also have AVN of the lunate, which is known as Kienbocks, and in this case, you actually do have avascular necrosis. And we already mentioned all of that. Yeah, there's a sesamoid bone there, normal. I don't know if any other ones have sesamoids, but yeah, you should be able to you should see sesamoids down here at the first metacarpal. So again, negative ulnar variance. There's an association. It's still not clear why it happens, but there's an association with avascular necrosis of the lunate and negative ulnar variance, which is known as Kienbocks disease. What view is this? Yeah, this is our axillary view in the shoulder. And yeah, we see an osteochromiale present. So if we look at the acromion process in this section here, we see a lucency extending beyond or extending through the tip of the acromion to the remainder of the scapula. It's consistent with an os acromiale. And again, you're only able to call it this once the patient is, once all the other bones have, all the other growth plates have closed. Okay? We saw this on the foot, but didn't have it in the hand. It is a human. And yeah, this is polydactyly. Normal, yeah. Normal variant present. Good, supracondylar process. Meaning superior to the condyles, and it points down toward the joint line. So yeah, with that supracondylar process, it helps to form this foramen, and we can't see it on here because it's a water dense structure, but we would see like there would be a ligament attachment presented here, and that would be Struthers ligament right there. But again, we can't see it because it's a water dense structure, and all the muscles and ligaments are all mashed together, so we can't fully decipher between them on X-ray. For the Struthers, for the supracondylar process or the Struthers ligament? Oh, there might be an olecranon foramen here, but yeah, the more obvious one I wanted you guys to see was that supracondylar process. Yeah, we're almost, I think this was the last one. This was the same case that we had as the rhomboid fossa. I think that was, I think just maybe a one or two more. Good, carpal coalition. So we're seeing it between the lunate and the triquetrum. Good catch. So yeah, so this is oblique hand, and this is P to A. Springle's deformity. So we see that this scapula failed to descend compared to our normal one down here. Yeah, we may see an omovertebral bone extending from the vertebral segments down to that scapula. And yet there is an association with Klippel-Foul syndrome. That's the one with the short neck, yeah. Yeah, we have that pseudotumor of that humerus. And if we look at this, so on the internal rotation view, it looks like there's this giant lucency of the humerus, but when we're looking at the external rotation, it completely disappears. So okay, easy to mistake for a lucent tumor. That right there. For humeral notch. Could happen with what's called hyperparathyroidism, but that's pathology. So you want to make sure that this is smooth. Make sure you can probably see it bilaterally as well. This one here. Sorry again, I'm trying to get you guys to a break right now. Positive ulnar variance, good. Says notice that there's some changes going on to that lunate. Remember with that positive ulnar variance, what appears to be a longer ulna can cause impaction in this area here. With the TFCC and with the lunate bone itself. Okay, so that was a very quick fire, well, not really quick fire, but a pretty dense study of the upper extremities. So you guys take 10 minutes. And we'll try to get through the lower extremity, and I'll try to see if I can get through some quick MRI stuff as well. So I'll see you guys at 12 after, okay?